Welcome to the first joint webinar between the Shoulder Surgery Societies of India and Argentina. It may sound strange that two countries so far away can have ties that justify this type of activity. There is a long journey between the two places and there are many cultural differences. But in 1924, the Bengali writer and poet Rabindranath Tagore made this journey. Tagore was the first non-European to win the Nobel Prize for Literature and may have been the only person to write the national anthem of two countries, India and Bangladesh. Tagore was a versatile genius, and his works have encompassed most of the important fields of creative disciplines: poetry, novels, dramas, songs and musical compositions, travelogues, articles embracing politics, philosophy, religion, science, even economy and ecology. He was passionate by education. Perhaps his best and most important work was Gitanjali. When I was 8, I read at school in Spanish The King's Postman. It is said that he was the one who named Gandhi as Mahatma, that means big soul. Although this has been deeply discussed lately, a figure like Gandhi deserves to be baptized by a poet. Both fought for the identity of India, although they did not necessarily always agree. But let's go back to Tagore's trip. He was invited to Peru for the centenary of the country's independence. Its itinerary was via Europe to Buenos Aires by ship and thereafter to Lima by train across the Andes. Unfortunately, while on board to Buenos Aires, he suffered a severe influenza. This held him up in Buenos Aires, and he expected that after recovery from the fever, he would be able to continue. But something was going to happen that was going to change his life. In this side of the world, there was a poet named Victoria Ocampo. She was born into an aristocratic family. She participated from her youth in the first manifestations of feminism and intellectual movements. She was fascinated by Tagore's works, and at that time she was around 30 years old, while Tagore was 63. Tagore was stranded at the Plaza Hotel, and he was visited by this young and unknown woman. She offered him a temporary accommodation in San Isidro at the countryside, 20 kilometers from Buenos Aires. Tagore never knew that she had to sell a diamond tiara to pay for his stay, because her parents, that were very conservative, didn't allow her to take Tagore to the family house. She was forced to rent the house to a political cousin. Tagore found here an atmosphere to get back to poetry. He had distanced himself from writing poems after the death of his eldest daughter. Tagore wrote about 30 poems during his stay, many of them dedicated to Victoria. He developed a deep and long-lasting impression about the intellectual excellence, humanitarian and liberal world outlook, and friendly disposition of this extremely beautiful Argentine lady. He left 2 months later, and they planned to meet again in Italy, but this was not possible. Only after 5 years in 1930, they met once again in Paris. Ocampo had organized the first international exhibition of paintings by Tagore. They never met again, even though Tagore invited her India several times, but was not possible. They were going through very complicated international situations, including the Second World War. They kept in touch, sending letters to each other, and this correspondence continued till Tagore's death in 1941. These letters reflect amply the depth and sublimated aspect of the relation between the two great intellects. Victoria received in 1968 the Prime Minister Indira Gandhi, who at the place where Tagore stayed, and she received from her the honorary doctorate from the University of Visva Bharati. But Indira Gandhi was not the only Prime Minister to visit Argentina. In 2017, Mr. Modi was for the G20 meeting and participated in a massive yoga session that is very popular in Argentina. And this is not a surprise because, by the own words of the Indian embassy in Argentina, the impact of Indian culture in our country perhaps transcends that in any other country. Distance is also not an obstacle for many streets in, for instance, the province of Kerala to dress in the Argentine colors every 4 years for the Soccer World Championship. Nor did the distance prevent the Indian delegation from being the largest in history at the International Congress that we organized last year in Buenos Aires. Neither the distance nor the difficult moments that we have to live nowadays will prevent us from continuing to build up this relationship of friendship, spiritual affinity, and culture. Our associations on the both sides of the world are ready to make this contribution. And this webinar is an example of what we pretend, and I'm happy to welcome our Indian colleagues and friends, and we will begin now with the first technical conference by Dr. Ram Chindaravan from Chennai, who will speak about scapular fractures.
Can anyone share your screen? Daniel, good morning. Can you unshare your screen, please?
Yes.
Thank you. Warm welcome to everyone. Thank you, Daniel, for a kind invitation and collaborating in this big first start of the Indo-Argentinean Shoulder Elbow Society Summit on shoulder fracture. As you said, we had really fantastic time visiting Buenos Aires last year for the International Congress and had a great time traveling around. It's a beautiful country, and your hospitality and the Congress, we enjoyed every bit of it. We would actually love to come back to Argentina when the COVID situation settles down. Now, thank you also for finding and designing this excellent logo of the flags of both countries, India and Argentina. And they have a lot of similarities in the flag logo as well. Thank you. With that introduction, I will just talk. My topic is on scapular fracture. The scapula contributes to 3 joints of the shoulder girdle: glenohumeral, acromioclavicular, and scapulothoracic joint. But on itself, it's a mobile platform. The scapula is an important bone. It assists in the movement of the shoulder joint. It's a mobile platform for the humeral head and the upper limb, and is a point of attachment of muscles, tendons, and ligaments. The prevalence is 1%. It's a high energy trauma. Often the associated injuries decide the outcome and the prognosis. 90% of them are minimally displaced, so conservatively treated. But because of that, it's largely forgotten in the settings of polytrauma. It's a strong belief that it will always heal, put the arm in sling. But it is not the case. I think I have a small problem. Okay, let's go. So, let me just check and come back. Sorry, give me a second, Daniel.
Yes, no problem.
Some problem. Small problem with my presentation. Can you move to the next talk, Daniel?
Yes, no problem. We can move to the next talk, so you have chance to fix that.
Yes.
The next, don't worry. The next talk is by Dr. Juan Martín Patiño. He will speak about craniohumeral instability. Are you ready, Juan? Can you share your screen? Go ahead when ready.
Dani, veo la presentación de Juan Martín.
¿Se escucha?
¿Me escuchás, Daniel?
Sí.
No lo veo a Juan Martín, veo la presentación, pero no lo veo a él.
¿Pero se escucha lo que él dice?
No se escucha.
Entonces avísenle. A ver.
¿Ahí estoy ok? Sí, ahí sí.
Empezá de vuelta.
Bueno. Sorry. Hello to everybody. Thanks to the Argentine Indian Society of Shoulder and Elbow Surgeon for this invitation. This is my topic today, recurrent anterior shoulder instability, our treatment options. We know that the glenohumeral joint is the most frequently dislocated. It is due to its particular bone anatomy and extended physiology, range of motion. Stable shoulder depends on the interaction between dynamic and static stabilizers. But when this stabilizer relation is broken, it may happen luxation or subluxations, microinstability, or a traumatic instability. After the first dislocation episode, many patients can recover their stability, but many others evolve to instability. There are well-known predisposing factors for this: males, young people, contact or collision sports, and associated bone injuries. These are the basic anatomic lesions after dislocation, like a bunker and heel sag. They are frequently small, but with recurrent dislocation, could evolve to more bone loss, weak capsule, and inferior glenohumeral ligaments. I think it's important to identify and treat associated injury, like extensive labral lesions, sometimes plus slap, as we can see here in different posterior arthroscopic views. The ALPSA, anterior labral periosteal leaf avulsion, here on the left a chronic MRI and on the right an acute MRI, and these are different anterior superior arthroscopic view of these kind of injuries. Or the Hagel, less frequent humeral avulsion of the glenohumeral ligaments. In the clinical examination, we have some important information to inquire, like different characteristics of the trauma and the luxation. We have to assess scapular dyskinesia, like in this patient. When we have patient like this, we usually perform rehabilitation before surgery. We have to assess the axillary nerve status if there is a parallaxity or voluntary dislocation as well. We do the application test at 45 and 90 degrees of adduction and external rotation. We know that when you have bone defects, we will see more instability signs and they are easy to reproduce. Other important tests are the sulcal sign and the sharp test to evaluate the posterior instability. I think that's important to perform the stability shoulder test with the patient under anesthesia before surgery, because we could obtain more information about the stability direction and the soft tissue and bone status. There are special X-rays incidents like a Westbone or a Stryker to evaluate inferior glena and Healy Sachs, but today I think that's mandatory to do an MRI and CT scan. We have important tools to the preoperative planning, like a glenoid index. This is a relationship between the less diameter of the inferior 2/3 of the affected glenoid with the contralateral glenoid. When you have less than 0.75, that means 25% of defects, that indicates bone block technique as Latarjet or similar. Our understanding of the bony defect measurement has evolved since 2000, when Burkhardt and De Ver talked about the inverter pair. In 2007, Yamamoto and colleagues explained the glenoid track concept, and in 2014, Di Giacomo and colleagues explained the on-track and off-track Hill-Sachs lesions, taking into account the bipolar defects. We know that if the medial margin of the Hill-Sachs lesion is within the glenoid track, this is an on-track lesion. On the other hand, if it is more medial to the glenoid track, it's an off-track lesion. This is the original paper in which the author explained how to measure the bipolar defect with the glenoid track concept and using CT scan arthroscopic measurements. Basically, they suggested two main techniques. When you have more than 25% of glenoid bone loss, they indicate Latarjet. When you have less than 25%, an arthroscopic bunker. And they add a remplissage procedure in every off-track lesion. Other important tool to the preoperative planning is the Instability Severity Index score, so-called ISIS. In this paper, Ball and Boileau, in a prospective study, evaluated 131 patients with arthroscopic bunker, all with anterior instability. They found 19 cases of recurrence. They determined risk factor for this recurrence. They stated 10-point ISIS score. Here on the table on the left, we have the different variables that they found. And when they had more than 6 points, they found an acceptable recurrence rates of 70%. So they concluded that with more than 6 points, the arthroscopic bunker is a contraindication, and they suggested the Victor Latarjet in those cases. This year was published this paper, Glenoid Track Instability Management Score, Radiographic Modification of the Instability Severity Index Score. This was the main objective of the authors. They add the glenoid track concept to ISIS. They compare decision-making with ISIS versus Shattime, this is the new score, using 3D CT scan versus X-rays. When they had more than 4 points, they indicate Latarjet. When they had less than 4 points, they indicate an arthroscopic bunker. Finally, using the ISIS score, they indicate Latarjet near 70% of the cases. On the other hand, using the new score, Shattime, they indicate Latarjet only in 14% of the cases. So they concluded that using only X-rays may lead, like ISIS, may lead to Latarjet over-indication. But how much bone loss is critical? There is some international consensus in taking into account 25% as critical bone loss. But last year, several authors started to talk about the subcritical bone loss. In this paper, the author presented 73 cases of military population. They divided in 4 groups regarding the bone loss. They found a failure rate of 12%, and the WOSI, the Western Ontario score, was higher than mean worse in defect over 13.5. So they concluded that this percentage, 13.5, is subcritical because may lead to lower WOSI, Western Ontario score, even in patients who did not have a recurrence of their instability. In this other paper, Ichoy and colleagues evaluate 43 patients with less than 40 years and less than 25% of glenoid bone loss. They divide in 3 groups the patients. They found a recurrent rate of 7%. And the WOSI for group 3 was significantly lower than group 1 and 2. So they concluded that the glenoid bone loss between 17 and 25 is the subcritical for these authors, mostly in males and contact athletes. And they suggest Latarjet in those cases like in the first paper. So in this both paper, they found different percentage as subcritical basis in the WOSI score because this percentage lead to low quality of life of this patient, but it's not clear why this patient had this result without recurrence of the instability. As regards the treatment, our objectives are to obtain a stable and functional shoulder, return to sport with the same activity level. There is a non-surgical management, but it has low success in young and active patients with instability. Our indications are low demand and comorbidities. As regards the surgical option that we are managing are the arthroscopic banker, the open banker plus capsular sheath, and the Latarjet is our third option when we need a bone block. The arthroscopic banker today is our most frequent surgery in number of patients. Our indications are anterior ability first surgery without or small bone defects. There are authors that extend the indication to defects with less than 25% of bone defects or less than 6 points of the ICS score. We have to be prepared to fix associated injuries, to evaluate the interval, and to perform a remplissage if it is necessary. Here on the right, the typical patient for arthroscopic banker for us, 25 years old, 3 anterior dislocation, with a banker and 5% glenoid bone loss, and a small heel touch lesion. We perform the technique and the lateral decubitus and longitudinal traction. It's important the portal placement. We usually do 3 portals, 1 posterior and 2 anteriors. And we follow the proposed steps for reattach the labrum to the anterior glenoid, as we can see here in the video on the right. The open banker plus capsular sheath is a technique that has been reconsidered by several authors in the last year, like Arciero in this paper. They indicate the open banker in different clinical scenarios, as we can see in the list here on the left. Our indications for open banker are 10 up to 15% of glenoid bone loss with non-track lesions in revision surgeries after failed first surgery, sometimes in contact or collision sports. Call my attention how this technique has been reconsidered the last year. This is a picture taken the last American Academy meeting. The last year, these authors published their own modification of the open banker, and they explain their indications: failed arthroscopy revisions, hyperlaxity, multidirectional instability, or contact or collision sports. Just to remember, the open banker plus capsular sheath, as the classic manner like Neer and Foster, has several modifications, like this one in 1991, the glenoid-based capsular sheath. This is a typical patient for our open banker indication. 22 years old, he had a prior arthroscopy 8 months before. He was referred for another center, presented pain and anterior instability. In this kind of patient in which we plan a hardware removal and we suspect a soft tissue, we don't doubt in performing an open banker. When we need bone block, our third option is the Latarjet. Remember the triple effect: the bone block, the capsular reconstruction, and coracoviction sling. Our indication in general are more than 25% of glenoid bone loss with big bipolar defects with an off-track helicage lesions. But as we said before, there are authors that extend the indication as a subcritical bone loss, 13, 17%. An author that extend in every revision surgery. It's important the graft position to avoid condyle injuries and non-unions. And this is the typical patient for our Latarjet indication. Multiple dislocations, more than 25% of defects. It's important to follow the different steps proposed to avoid complications, because as we know, Latarjet sometimes has several complications. This is a patient with a failed Latarjet male, 43 years old. He was operated 1 year before. He had a new trauma, and he presented pain and instability. In the anterior posterior X-ray, we can see a broken screw and in the CT scan, we can see an coracoid non-union. This is the important instability with engaging anterior dislocation with the patient under anesthesia. In this difficult scenario, we prefer an autologo iliac crest like Aiden Ivinet's procedure. We can see complications and recurrent rates in every technique. Why? There are relative patient factors, anatomic factors, but we must to avoid our technical factors. Failure to identify causes of the instability, failure to recognize pathological lesions, inadequate techniques or inappropriate rehabilitation. As final considerations, the treatment must be according to the patient and pathology scenario. We have to analyze advantages and disadvantages of every surgical options, recognize bone defect sizes, labral injury extensions, and uncommon lesions. The outcomes in general are according to these items. Pay attention in postoperative care and the rehabilitation. We know that arthroscopic bank and Latargia are most popular today, but remember and consider the benefits of the open banker too. Thanks for your attention. We'd like to invite you to the Argentine Society online courses. Thank you very much.
Thank you very much, Juan. I don't know if there is any question in the group. I don't see questions in the YouTube channel, or is there any question on the Indian side?
Sure.
Ram?
I don't see any questions yet.
Okay. So, well, we can go ahead with your conference and give people the time to go ahead with questions, and we can answer those questions after your conference. So yeah. Let's go ahead with your conference.
Yeah, thank you very much. Sorry for the technical error. So scapula, though, is an important bone, is usually forgotten in polytrauma because of the multiple associated injuries taking priority, and it's a strong belief that it will always heal and is put in a sling place treatment. But it is not the case. Some cases lead to symptomatic malunion. So why there is no consensus in scapular fracture? It's a rare fracture. There's no standardized method of measuring or classification of fracture displacement. Different outcome measures are used, and only case series. So I'm here to show you 8 of my cases to show how I handle them. So it's very important in the clinical examination to check and document a neurovascular status, especially sensory examination to check nerve injury. It's very important. Classically, 4 X-rays have been described. A difference between a shoulder AP X-ray and a scapular AP X-ray taken in a tilted manner is that you could see the scapula in profile with the clavicle and the acromion. It's mandatory to do 2 X-rays lateral view. One is the shoulder axillary lateral view to check the glenohumeral articulation. And second is the scapular Y view to see the alignment of the scapular blade with the anterior posterior processes. If you suspect a displacement of the fracture or articular involvement, please get a 3D CT scan and also subtract the humerus to see the glenoid fossa, because the integrity of the glenoid is very important. A couple of measurements have been described. One is a GPA or glenopolar angle, which is the angle between the plane of the glenoid and the lateral border of the scapula. Second is the mediolateral displacement. The difference between this affected shoulder and opposite shoulder is marked. Based on the location of the fracture, is the common in body and spine, followed by glenoid neck and the fossa, and then the acromion and coracoid processes. Let us look at the cases. A 44-year-old man, chest injury and a knee fracture and a shoulder fracture. If you look at the CT scan, it has the scapular body fracture only, the glenoid is intact. So I treated this patient conservatively, arm in sling support, ice pack, mobilize as comfortable as early as 4 weeks he could have the movement. The key is the scapular muscles sandwiching the scapular bone will mold it and heal better. So mobilize early. This is an example of a 25-year-old man presenting 3 weeks after road traffic accident, has the scapular body fracture as well as a glenoid intra-articular fracture, displaced, and is 3 weeks. So I decided to treat this operatively. There are 3 surgical approaches for the posterior direction. Whatever you do, beware of the nerve anatomy and stay close to the bone. This is the classical Jude approach, incision, and the deltoid is erased from the acromion attachment. I prefer the subdeltoid approach, is a direct posterior incision on the shoulder, and the deltoid is retracted up, and the plane between the infraspinatus and teres major is used. I use the lateral position with the C-arm coming from the top. The glenoid ORIF is done with the joystick reduction using the wires, and I have used here a couple of hand system plate with the 2.7 millimeter screws. Because I also do hand surgery, I have this available all the time. So this is the closure, and that is him at 6 months follow-up. So well-healed fracture glenoid as well as the body fracture has healed, leading to a good functional outcome. You could see the scar on the back of the shoulder. So scapular body fracture heals well, rarely leads to symptomatic malunion. You consider surgery only if the displacement is significant. Like this 25-year-old man presenting after road traffic accident with the crepitus in the back of the shoulder, pain on movement of the shoulder above 90 degrees. He has got significant frontal plane displacement of the fragment. So I use the pillar approach, the direct approach to the lateral border of the scapula, approach the proximal fracture, is a small hand system plate, and the distal fracture through the same incision and plated. And this is the closure, and that is his range of movement at 6 months follow-up. So let us look at the second group. It's a superior shoulder suspensory complex described by Gauss in 1993. You have a clavicle, ACJ, and acromion strut on the top, and the clavicle, coracoclavicular ligament, coracoid strut on the front, with the processes acromion, coracoid, and superior glenoid connecting below. This forms a circle. This suspensory complex suspends the shoulder. A single disruption could be in the distal clavicle, or ACJ disruption, or coracoid process, or acromion process. As a good review article on these scapular processes fracture for those with interest to see. The basic is the coracoid fracture needs surgery attention if the fracture is proximal to the level of coracoclavicular ligament attachment. The indication for surgery is this, as well as symptomatic non-union. The treatment is mostly a screw fixation. Acromion fracture, the indication for surgery is on type 3, which is the displaced fracture with the reduction of subacromial space and mechanical impingement of the cuff. Also, symptomatic non-union, malunion should be addressed as well. The common type of fixation is ORIF using tension band fixation, or increasingly we use locking plates here. Double disruption of the complex, which is the glenoid neck fracture and the midshaft fracture of the clavicle, is the classical floating shoulder. So it's an example of a floating shoulder injury in a 60-year-old man after road traffic accident. You could see there is a glenoid neck fracture and also a clavicle midshaft fracture. But do not jump to surgery because it is a floating shoulder, because these injuries are minimally displaced. So I treated him conservatively, leading to a good final outcome with healing of both fracture and also restoration of full flexion, abduction, and rotation of the shoulder. But this 31-year-old man after road traffic accident comes with a floating shoulder, but he has got a displaced midshaft fracture clavicle as well as displaced fracture neck of the scapula. The two disruption, the glenopolar angle is, the difference is less than 20 degrees and the glenoid is intact. So I treated this clavicle with a pre-contoured clavicle locking plate and left the neck fracture to heal on its own. If you look at that, the fracture is healing nicely with restoration of normal glenoid facing. That is his range of movement at 3 months follow-up. There's another case, 36-year-old man, a bike accident. You could see the hemothorax on the chest with the multiple fracture ribs and the floating shoulder injury. So that is the clavicle fracture, the neck fracture. If you see, there's a GPA difference is less than 20 degrees. There's no tilt of the glenoid. Glenoid fossa is intact. So I decided to fix the clavicle fracture and left the glenoid neck alone for that to heal. I fixed the glenoid neck fracture only if there is a GPA difference of more than 20 degrees compared to the opposite side. A comminution at the neck level is not an indication for surgery. So that is his range of movement at 2 months follow-up. I mobilized them day 1 postoperative. And that is the range of external and internal rotation this young gentleman has. So this is supported by literature showing good to excellent results in over 90% of cases when you fix the clavicle fracture with the floating shoulder girdle injuries. So the triple disruptions have been described with the combination of coracoid and acromion fracture with either involvement of clavicle or ACG. With Indian road traffic status and a high velocity injury, I have a few cases of multiple fractures in the scapula. I will show a couple of examples on how we dealt with them. So this is the first of this patient, 43-year-old policeman after road traffic accident, has this significant injury to the right shoulder. You can't see much clarities around in the plain X-ray. This is his CT scan showing the extent of injuries. I will list them for you. So a scapular body fracture, coracoid process fracture, acromion process fracture, acromion spine fracture, and the glenoid intra-articular fracture. So I decided to address the serious conditions of this list to restore the strut mechanism of the superior suspensory complex. So acromion process, acromion spine fracture, and the glenoid fracture need to be addressed. So this is the posterior approach to address the acromion process fracture with the tension band wiring. And I plated the acromion spine fracture using a clocking plate. I used to use a pre-contoured scapular plate in UK, but now in India, I use either the lateral clavicle plate or a distal radius plate. So this is the post-operative fixation of the posterior aspect. I closed the wound. I moved to the sitting position and did an anterior approach to fix the glenoid fracture from the front. So this is his 5-year follow-up. I called him today to check how he is on. He has been now to his corona duty on his favorite motorbike, and he has got a very good range of movement of the right shoulder as well as rotation. And this sort of results is possible if you restore the strut mechanism of the shoulder to get the suspensory complex in place. So the last case of the series, the 30-year-old man, right-handed professional percussionist. He was involved in a road traffic accident. He had fracture of multiple ribs, hemothorax, fracture spinous process of D3 to D9, and the right shoulder injury. This is a very common scenario for a scapular fracture. As I said before, the associatory injuries take priority. They have to be treated. The patient general condition should be improved. Then only we will sort out the scapular fracture. The only exception is the fracture dislocation, which you need to address as early as possible. Otherwise, they can wait for some time. So this is the chest X-ray, and that is his shoulder X-ray. If you look at this fracture, he has got a scapular body fracture. He has got an AC joint subluxation and acromion spine type 3 fracture. You see the angulation, the mechanical impingement it can cause. The glenoid iceberg type 5 fracture. So here I have to address the acromion spine fracture and the glenoid fracture. So I used a curved incision, more like a Jude incision, but the inside approach is the subdeltoid approach between the infraspinatus and the teres major. I plated the glenoid on the posterior direction, and through the same incision on the top, I plated the acromion spine with the lateral clavicle locking plate. So that is after closure of the osteoperiosteal layer over the scapular plate. It is important to do this, otherwise the people will have metalwork prominence. So that is him at the 3 months post-operative. You see the scar and the range of movement at 3 months follow-up. After fixation, I let him have a sling and mobilize the shoulder as comfort allows with assisted forward elevation up to 90 degrees as comfortable. So that is his range of external rotation and internal rotation after his glenoid fracture. So now he sent me this video. This is the Tamilian percussion, traditional percussion instrument called tawil, and is back to playing this for about 1 hour to 2 hour program without any discomfort in the shoulder. So complications of the scapular fracture could be, as I said, neurogenic. At the time of injury, it's important to recognize and off conservative treatment, occasional scapulothoracic crepitus. If the glenoid fracture is neglected, it can lead to arthritis, stiffness, or instability. The complications of operative treatment is mainly metalwork discomfort. I don't recommend routine removal of this plate or fixation. When it is causing discomfort, you need to remove it. To summarize, it is important to assess and treatment the associated injuries that takes priority. You have to respect the scapula, don't ignore, understand the pattern of injury with the 3D CT, mostly conservative treatment, except if there is an articular fracture, gap, or step more than 4 millimeter, or significant glenoid involvement. Displace the clavicle fracture and scapular neck. This is the classical floating shoulder. My recommendation is to fix the clavicle first and fix the glenoid neck if there is a significant displacement. And multiple disruption or multiple fracture, restore the key strut to gain the mechanism of the shoulder suspension. Thank you very much.
Thank you very much, Ram. Was a great presentation. We have some questions, so we can, before we move to the next conferences, make the questions that we have for Dr. Juan Martín Patiño and Dr. Chidambaram. Juan Martín, there is a question about your election for arthroscopic banker. If you make any difference between collision sports versus contact sports, just contact sports.
No, our election is according to our indication is according to the mainly bone defects more than the typos. For nowadays I'm not working in a team, in a special sport team. Perhaps it's for this is the explanation. I don't have a lot of contact sports patients, but my the first thing that we evaluate is how is the bone stock in the glenoid aspect and in the heel sach lesions. If the contact sport with an important glenoid bone loss, we prefer la target. We have to access the different measures, no?
Miguel Capomasi is with us. He is perhaps the person, or for sure, the person who has more experience on scapular fractures. Miguel, do you have a question, something to comment about Ram presentation? What do you think?
Bueno, gracias, Dani, primero por la invitación.
Thank you, Daniel, first for the invitation. If anybody heard the presentation that we had with our friends from Bolivia about 10 days ago, and my topic was scapular fractures and floating shoulder, we will all agree that in 99% of the notions, we agree with what has been said so far. I think that you have to select carefully scapular fractures that have to be treated surgically, mainly those that combine lesions, polytrauma, high energy trauma. And with regards to the approach, we absolutely agree. If we have seen the approaches, they are no longer the big approaches proposed by Joudet, where you denuded the whole infraspinatus area with a risk of affecting a nerve. We prefer now simplified approaches, looking for going into the place between the teres minor and the infraspinatus. I have two questions to ask to the doctor after this excellent presentation. One is, how do you approach a type 3 glenoid fractures where there is a proximal upper fragment of the glenoid and the fracture line that ends immediately medial to the attachment of the coracoid process? And the second is whether you have had to do, in any case, I haven't seen it in your presentation, an approach to stabilize also not only the superolateral angle, that is a lesion of the scapular neck, but both pillars, the superolateral and the superomedial angle.
Okay. Thank you, Dr. Capamosi. I think is a very important aspect that he brought in. The previous approaches to scapular was the extensive approach, the Jude approach to expose everything, but we no longer do that. That's important. The questions I would like to answer, number one is a type 3 glenoid fracture where the fracture stops short of coracoid. What I didn't show that here in those simple fracture, because I classify them as a simple fracture as well as the glenoid is concerned, because I could address them with arthroscopically. That is the best way to address, because you could have the percutaneous wire and screw fixation coming from Neviasa portal from top to bottom to fix those intra-articular fracture. If the fracture is extending more medially, then we have to approach it through an extended approach from the anterior open direction. But that is not necessary in many occasions. Second question is that whether you address the medial pillar. I think in my practice, I address the lateral pillar and the superior pillar. Unless the fracture is very much displaced, I don't go for addressing the medial pillar. The important strut is the superior, which is the acromion spine extending to the acromion, that is a superior suspension. The lateral pillar importance is because it is supporting the glenoid neck and the glenohumeral joint. So I would restore only these two pillars and ignore the medial pillar.
Thank you, Ram.
Let it heal with the nature. Because if there are a lot of fractures, I think my recommendation is to address the priority fracture first, restore the key strut. Do not go, I do not like to go fix every fracture in the scapula. Let some part of the fracture heal by nature.
Good, very clear. We have some other questions for you, Ram. One is related to the conservative treatment. This is a question by Noelia Mercado. She wants to know, what is your timing when you begin with partial load, when you move to complete load, when you choose conservative treatment?
Yes, that's the first patient scenario I showed. The conservative treatment originally described by Eidberg is mobilize as comfort allows, because we are expecting the scapular bone being sandwiched in a lot of muscles, subscapularis, back, and all the other cuff muscles with the spinal muscles, front and back. They will mold the fracture. So I would recommend to mobilize as comfort allows. If the pain is better, I will ask them to mobilize. The first thing first is ice pack or cryocompression therapy to reduce the swelling, because many of these scapular fracture will have a lot of swelling. So first thing priority is the control of swelling by ice packing or cryocompression. Second, I will rest them in arm sling. But as soon as the pain settles down, we will allow the patient to mobilize the arm.
Good.
And at 4 weeks, you can get rid of the sling and mobilize with the supported forward elevation as much as comfort allows.
And Ram, we have another question by Ana Maria Santos. What about your post-operative timing? How long do you maintain the sling, and when do you begin with physiotherapy?
Same, see, if post-operative, if we have fixed the superior strut with a plate and the glenoid neck if necessary, then we are actually making this as a conservative treatment of the remaining fracture in a complex scapular fracture. So I would recommend the same thing: ice pack, arm sling, pendulum movement starting straight away, and then assisted forward elevation exercise up to 90 degrees as comfort allows with the sling, but keep the sling for 4 weeks maximum.
Good.
My recommendation is, my practice is, if it is stable fracture, immobilize as comfort, arm in sling support. And if it is unstable fracture, fix the main strut and then mobilize as comfort allows.
Good. And one last question by Nahuel Cabrera. He wants to know which is your indication for type 2 floating shoulders when you have the disruption of the coracoclavicular ligaments.
Sorry, I didn't get that.
When you have a tear of the coracoclavicular ligaments,
yes,
which is your indication in those cases of floating shoulder? What do you do?
I mean, we are talking about is the acromioclavicular joint disruption.
Yes.
Yes. If the acromioclavicular joint disruption is the combination, I would address with the coracoclavicular repair in an acute setting. With the tape, with the like a dog bone anchor tapes system, I would address it.
Good. Perfect. Well, I have received some information from India. They have there around 800 attendees to this webinar, that including our participants. This is not the best time for Argentina in Saturday morning, but we have around 900 participants now in this webinar. Thank you, Ram. Now we will move to Dr. Ashish Babulkar. He's from Pune, close to Mumbai, and he will talk about glenoid fracture, as I see, in a very passionate way.
Thank you, Daniel. Es un placer hablar aquí. It is a pleasure to talk here. And in the interest of your health, I think I should continue in English. Lovely opportunity that this is a good collaboration between India and Argentina. Enjoyed both the previous talks. I will quickly, in the compact manner, in the next 12 minutes, speak on glenoid fractures. So today's agenda would be to cover classification, understand which ones to operate. We'll give you the option that there is a conservative option, arthroscopy, open reduction. Most importantly, I'd like to dwell on the importance of imaging, that is very critical, a brief about approaches and a couple of examples after that. So number of classifications, and I'm not too happy because everything doesn't fit into a perfect classification. Often one has patients who have such complex fractures that they don't fit into any particular classification. The Eidberg classification was predominantly described for scapular fractures, but has been extrapolated to glenoid fractures. And then here you have the old OTA classification on the bottom right here, where a very simplified version as extra-articular scapula or inferior articular glenoid and entire glenoid is too simplified. However, because it is popular, we continue to refer to the Eidberg classification, and there's a fair bit of unanimity between all of us. I particularly appreciate this classification, which is the AO-OTA classification, which was described in JSES in 2012, and very simply describes glenoid fractures very specifically, apart from scapula, as to the infra-equatorial, trans-equatorial, and both pillar affections. On the right side, you have these comminuted versions, and here you have these are very common associations where you have these Eidberg 2, where there is a transverse fracture across the glenoid, a superior inferior fragment, whether it's low, middle, and superior. So that is usually my preference. Now, this is a patient who has a Bony Bankart. Now I understand the threshold between a Bony Bankart and a fracture anterior column glenoid is very fine, but I'd rather like to look at them as intra-articular fractures. And this is because she's 65, the x-rays look very innocent. But if you look very closely here, you will realize that on this x-ray here, you can see a fragment here. Please take that seriously because the x-ray is fairly naive, but when you look into the CT, you realize it's fairly big. In an elderly patient, because the bones are osteoporotic, it is more likely to be an osteoporotic fracture. And if it is stable, like this lady here, I have managed that conservatively with a good result within 2.5 to 3 months. So there is a role, provided you monitor these fractures on a regular basis. This is an interesting paper by Spiegel et al. In 2013, where they had 12 patients who had very smaller fragments, less than 5%, and they conserved most of them. And I think 3 out of those 12, almost 1/4, had instability and needed surgery. Amongst the other 13 patients who had a larger fragment, average fragment size was 15, you would realize that almost excellent result in 54 with surgery, but and moderate results in 15, poor result only 1. So surgery can be useful in larger fragments, but do be careful. Even the smaller fragments, which are on the average 2%, had 25% chances of instability. When you're dealing with a Bony Bankart, my inclination is always to do arthroscopic because my core training is arthroscopy. But apart from the Bony Bankarts, even the type 2 Eidbergs, I would prefer to treat arthroscopically. But each one is different. The Bony Bankarts, I prefer to treat with a double row approach. And this one is a elderly patient, almost 60 thereout. And you would see that this X-ray clearly shows a fracture here going from the transglenoid entering into the scapula. X-ray looks doable. Honestly, you could treat him quietly, but the CT scan reveals fracture lines moving all across. When you have a fracture line across the scapular body and involving intra-articular, then one needs to take it seriously. This fellow is a professional golfer, although he's 61 years old, and we offered him both the options and he chose the surgery option. This is the fracture that Miguel referred to in the previous question about the type 2. Now this looks reasonably easy and simple to do, but this is the Nevisor portal and this is arthroscopically fixed from top to bottom, and he's gone back to he's the national golf player. And you can see arthroscopically the fracture is highlighted much better here, and look at this post-reduction X-ray, it is almost perfectly reduced. So younger patients, I would offer them an arthroscopy. Don't rely on the X-rays to give you an innocent approach. The 3D CT scan will give you a much better understanding of the quality of the fracture. And then you can use a probe from the posterior lateral portal to help your reduction, and then use a cannulated guide wire and pass in a single screw from top to bottom through the Nevisor portal. As far as the Bony Bankart is concerned, the standard Bankart surgery techniques that was described by Juan Patino may not apply because these are big fragments and they need a very special approach to treat. I will fast forward this video in your interest. What I prefer to do is to insert one anchor very medial, which is double loaded, 4 sutures, pull those sutures underneath that fragment medially, and then pass in 2 more anchors, which are single loaded on the edge of the fracture line. So here you don't need to pass any suture passer. All you need to tie is the medial to the lateral row. This is a double row technique that I prefer to. And when you see, you tie the medial sutures to the lateral sutures in a crisscross manner. So the top ones go inferior, the bottom ones go superior. And as you tighten them, the whole construct will get reduced, compressed into a hairline reduction. It is very important to ensure that the fragment doesn't tilt. With a single row, it is very common for that fracture fragment to tilt inside the glenoid and spoil the articulation as such. So this is my preferred technique on these patients. We'll go to the next. Right. So this is a patient. He was operated with a bank card elsewhere in 2019. Had a 17. Sorry. 2 years later, had a slip and fall. He's young, 27 years old. Has had 3 dislocations after that. When a patient has suture anchors inside and he redislocates, it's very common to have a bony bank card because of the fatigue fracture at the fracture site. So again, X-rays look fairly innocent. On the actual X-ray CT scan, you'd see a small fragment, but it is the 3D CT scan, sagittal reconstruction with subtracting the humeral head. That is the instruction I give to my radiologist, and you can see it's a substantial fragment, not something that should ignore. So be careful. The X-rays can be fairly innocent, and these were his previous sutures which we had to remove in advance and then mobilize his fragment and ensure that we prepared it very well. You can see some cartilage changes there significantly, but here you have to prepare the bony fragment very well. And here you will see that I have released the labrum in such a manner. We'll do a shift, and all that here is the bony fragment just at the bottom, and that's the entire bony fragment here. You can see that. And then this is the final repair with the double row technique that I just described. And you will see at the end that not only is the IJHL very strong and taut, but you've got a good bumper and you've got sutures passing across from the medial to the lateral. It's frightening to have the medial anchor, and you need a special subscap portal for that, but I shall detail on that in the next few slides. So this is another lady who's had a bony bankard, elderly lady, very unstable, would dislocate every time she abducted her arm, and this is her construct between the medial anchor and the lateral anchor. You don't need to use any suture passer on these patients. Another patient, double row, bony bankard, you can see that the entire bony fragment has been brought in level, flush with the parent bone, and a hairline reduction on these. And this is how they will look. These are orthocords, so most of these will, 60% of this will dissolve over time. So even the sutures are bioabsorbable along with the anchor so that they will not cause a hindrance intra-articularly. It is important, and I always do a repeat CT scan between 3 and 6 months post-op to see and confirm that the entire fragment has been uniformly integrated, because this fragment is rendered avascular. And in some patients, it will dissolve eventually. And if it dissolves, it leads to a bone loss. And that is why the purpose of getting the CT scan done. In the previous days, we used to use metal anchors, so 5 mm anchor medially and 2.8 anchors laterally, and that's how the construct will look on an X-ray. Now we use the bioabsorbable anchors, so we can't see them on the post-op X-ray. The point I was trying to make is the medial portal in these patients has to be very medial, and that's why it skirts along the brachial plexus. So we always expose the axillary nerve, ensure our cannula, long cannula, is away from the axillary nerve, because the first 2 cases that I did had a lot of tingling numbness in the axillary nerve and the radial nerve, which lasted for almost 2 to 3 months. So you have to be very careful with the medial portal. So this is another patient that we're talking about, 39 years old, had a bad road traffic accident. Right shoulder was with a drop arm. Clinically, he had a complete drop arm, no strength, and was peculiar. And the X-rays, if you look like a GT fracture, but there was something happening here. And if you look very closely, you'll see that there is a funny appearance because there's a break in the cortex here. If you look here, you'll think this is fairly innocent and doesn't reveal the same there. If you look at the CT scan, a 2D CT scan is inadequate to give us the extent and gravity of the situation. And this is the sectional CT scan at the lower level, just shows a GT fracture. At a higher level, you see a nice bony bankard there coming. Again, underwhelming. Again, it looks fairly naive and innocent. And if you look here, this is the fragment here. And then until you do a 3D CT scan, you can see how big that fragment is. So this is a very big fragment. It is displaced always rely on the 3D. And now we have a double problem here, a GT fracture and a displaced glenoid fracture. So we've done an arthroscopic fixation of the glenoid fracture. At the same time, we've done a double row suture fixation for the GT fracture along with. This is another patient who's 55 years old, and you can see this is a much more grievous injury. This is a type 3 where the fracture line is going medially, but there's a lot of combination on the glenoid side, and the fragment this time is posterior. So this is much more stressful than the previous. This is of course done open. So we do a posterior modified Jude approach. We've done a plating. So this is a T-plate posteriorly. Anteriorly, we've done the suture fixation. You can see a coracoid osteotomy here to allow me to get a better view on this fixation. This is another patient who is an acromial fracture in combination with his comminuted GT fracture. We've got suture anchors combined with a screw fixation for his glenoid along with the acromion, again an open technique. When I go posteriorly, I use a modified Jude like Ram described. You go in the internervous plane between teres minor and infraspinatus. Very rarely do I have to take down the deltoid. My preference is again to keep the deltoid intact, and for glenoid fractures, you can use nice retractors to help evaluate these. This one is again type 3 that's extending into the scapular column. So use just a 2-hole reconstruction plate along with the screw to fix the acromion, which is a simultaneous approach. This one is a much more significant injury here, and you can see that there are several components of the scapula that are damaged. You've got the glenoid involved, and then you've got a posterior column involved, and you've got a clavicle fracture in addition. So if you had to use 3 different approaches, the Nevaser to fix the superior and inferior glenoid fragment first, then we went to do the clavicle fracture, and the last was a posterior approach to fix the scapular column. And here we've got this X-ray done after 8 weeks. It's healed nicely. This is a young guy. So the true AP and the outlet X-rays will explain that the fracture fixation has been satisfactory. The entire column has been reconstructed. But these are tedious fractures, take a long time and planning. So it is important to decide. I do them in the beach chair position to facilitate all 3 approaches simultaneously so that I don't like to change the patient position once it is draped. So in conclusion, I think displacement of more than 5 mm is significant because these are intra-articular fractures. Please, whenever you suspect any form of glenoid fracture, go and do a 3D CT because the X-ray will miss everything. You might need multiple approaches when there's an anterior and posterior column approach. My preference would be the larger fragment. So usually go posterior, fix that up, and then come in anteriorly and do the anterior fixation on these patients. If it's the Eidberg 2 or Eidberg 3 or a Bony Bankard large, I would always prefer an arthroscopic. But even if you do an open, it doesn't matter because the results are pretty similar as long as you reduce the articular fragments anatomically. Any fracture that is 6 weeks old in my hands is bad news because it has malunited and it's very difficult for me to put them back into the original position. Thank you very much for your attention. Gracias, and hope we can collaborate in this manner more frequently. Thank you, Daniel. Thank you, Team Argentina. Thank you, Lydia, for your translation.
Thank you very much, Ashish, for your great presentation. I'm sure that Miguel has something to say or ask. Miguel?
Daniel.
Daniel, dos cositas simplemente porque las charlas...
2 things, because the talks are very thorough. I think that you have to establish a difference between glenoid fractures of the rim, for instance, the most common one, a Bony Bankard, from those of the glenoid fossa per se. Secondly, I think that the glenoid fracture that has been more difficult to approach since its fixation is from the top to the bottom is the type 3 fracture where we have a superior fragment of the glena, which includes the attachment of the coracoid, and it is very difficult to approach openly. So that I think that arthroscopy, speaking of fractures of the glenoid fossa, makes a very, very important contribution in that specific type of fracture where you can reduce using pins, joystick type, corroborating arthroscopically that the reduction has been good, and then fixate with percutaneous screws. But in my practice, this is one of the glenoid fracture types that is more difficult to resolve. But I agree on every aspect with both talks, and I thank the participation.
Thank you, Miguel. There is a question by Juan Martín Patiño. Juan?
Yes, to Ashish, a great talk, very, very good technique to fix in a bridge way the fragment. In relation with the Miguel commentary, how do you decide between a bony bunker and a more important size of the fragment to decide to do it open or arthroscopically? Because I saw big fragments in the arthroscopic technique too.
Juan Martin, thank you, gracias. That's right. Any fragment that is a sliver and less than 1/5 of the diameter, I think should be treated with suture anchors, because often it is a small plate of bone. If we put screws inside that, it is likely to fragment and further rupture. There are very many techniques described of how to handle a bony bankard. My friend Hiro Sugaya uses a special bone needle which goes through the fragment. In my hands, that splinters the fragment. And I'm very scared that if it becomes comminuted, it will make things worse. But Sugaya has excellent results with his bone suture technique. And I prefer this indirect technique of double row. When the fragment is larger in context, such as 1/4 of the glenoid diameter, anything that is thick and will take 2 cancellous screws, I will fix them with screws. Whether one does them by an open technique or an arthroscopic technique doesn't matter. Previously, 5 years back, I used to treat all of them open and I used to get a much better result. And then you become adventurous and you want to explore newer territories. So the advantage of arthroscopy is, number one, you get a perfect hairline reduction. But one must know how to play with the nerves, because the medial approach is very close to the nipple line. And so as my cannula is coming in, and we use big 8-inch cannulas so that we bypass the axillary nerve. And as long as you get that anchored medial column into the scapula, which is medial to the fracture line, then you just do this indirect suture technique. But even if you're doing the CC screw technique, passing the guide wire and the drill is very risky. So always use a cannulated cannula so that you can pass these safely without damaging the nerves. I realized this because the first 2 patients had neurological symptoms, and so we came up with this 8-inch cannula, and then we passed them with the CC screws, and that works well. Only thing is, you need a very big screwdriver. Thank you.
Okay, thank you very much.
Good. Well, we will move to the last conference by Dr. Juan Pablo Simone. Juan Pablo is actually nowadays the president of the Argentinian Shoulder and Elbow Society, and he will speak about fractures of the proximal humerus. Juan?
Thank you. ¿Te escucha, Daniel?
Perfecto.
All right, can you see my presentation?
Yes, we can see it.
Okay, thank you. All right, so now we're going to move to another topic. These have been excellent topics, the ones we've listened before. Thank you. Now we're going to address proximal humerus fractures, and we're going to talk about a bit more about what is controversial in decision-making procedure. So we know that proximal humerus fractures are common amongst the elderly population, and treatment options will depend on a lot of factors: fracture, the type of fracture, displacement, bone quality, patient, which is very important, its age, activities, expectations, and the surgeon, of course, his expertise and process of thought. So for many variables, we have a lot of options for these patients. Now we know that this is an age-related injury. Very few patients are young patients because of high energy fractures, but over 70% of patients with proximal humerus fractures are elderly patients with low energy fractures. And the thing about these elderly patients is that as we have increased life expectancy, we have a much wider range of different types of patients. Not all these patients are the same, and they don't have the same expectations or limitations. So we can see these are two mirror-like images. It's exactly the same fracture, a varus displaced fracture, but one patient is 61 years old, and the other one is 94 years old. So you can see they are at the extremes of this curve, at the extremes of the age-related injury, and they probably will need different treatment. So we have to be very selective on what we do. So treatment options will be basically divided in two types, either non-operative, which are most of the cases, or operative. And if it's operative, either reconstruction procedures or arthroplasty. So the goal of this presentation right now is to review different settings and current trends for proximal humerus fractures in elderly patients. As we have seen for many variables, there are many options. So the first thing we ask ourselves is, who needs surgery? Do we do non-operative or operative surgery? Well, there are a lot of factors that we have to take into account for this. So we know that most patients will succeed with non-operative surgery. So a lot of papers show that between 72 and 92% of proximal humerus fractures are treated successfully without surgery. They do not need surgery. And what are the factors that influence our decision for non-surgical treatment? For a start, fracture type and degree of displacement. Most of the fractures we see are either non-displaced or minimally displaced or have acceptable displacement, and that is why they do not need surgery. And minimally displacement or acceptable displacement usually goes around these terms that is less than head-to-shaft displacement of 50%, varus or varus deviation 20 degrees, and 5 millimeter graded tuberosity displacement. Now, these patients can be successfully treated without surgery. Even more, if they have some minimal displacement or acceptable displacement, they will do fairly well. Now, the other factor, which is the most important one today, is the patient itself, its age, activities, and expectations. So we have literature that says that no matter what type of fracture, if it's displaced, even if the patient is elderly, they might not benefit from any surgical procedure. So different published papers are showing that there is no significant difference for functional outcomes between operative and non-operative treatment. Of course, there is a high risk for reoperation in the operative versus non-operative treatment. And some other published literature highly recommends not do any surgery for displaced fractures in elderly patients. Now, this is a bit controversial for us, and there may be some selection bias for this patient. But if we get patients like this as orthopedic surgeons, a 78-year-old male who is an independent lifestyle patient, lives on his own, and is not in a nursing home and needs his arm, it's very difficult for us as orthopedic surgeons to just let him go by. So evidence-based medicine has shown us that he might not need surgery, but the question we have to ask ourselves as surgeons is, can he benefit from surgery? Can we make him better than he is right now? So there are some randomized controlled trials talking about surgery versus non-operative treatment. This is internal fixation versus non-operative treatment in elderly patients. And there seems to be an advantage in functional outcome and quality of life favoring locking plate as compared to non-operative treatment, but still complication rate and reoperation rate is high for internal fixation. So we have to take that into account. Now, what about hemiarthroplasty? Hemiarthroplasty versus non-operative treatment in elderly patients? Well, there is some advantage, especially in the quality of life for these patients in terms of pain relief. Pain relief, but not function. Most of the patients with hemiarthroplasty would not get better function as non-operative treatment, but they will surely have less pain. Reverse shoulder arthroplasty, which is now very common to use, compared to non-operative treatment, we might not think it's as beneficial as we see. This paper, randomized controlled trial, has seen no significant benefit clinically or functionally, at least in the short-term follow-up at 12 months. But there is a trend towards higher pain score in the non-operative for surgery versus non-operative patients. So not only do we have to assess fracture type and patient, age, activity, and expectations. But our surgeon experience is very important because a lot of times we can tell a patient he might do well without surgery or with surgery, and they ask ourselves, what would we do for them? So this is an 87-year-old patient with a displaced humeral shaft neck fracture. And so we have to evaluate this patient very well. So she was independent, she was very healthy and a very active patient. So we went along and did ORIF for this patient. And fortunately, she did very well. She did not fall into that 30% of patients with complications. For her, this probably is a very successful treatment. So we have to balance out for non-operative treatment, evidence-based medicine for sure, but also our experience-based medicine, and most importantly, patient needs, and talk about potential benefits and complications rate, because as we see, not all the elderly patients are the same and have the same needs. So once we ruled out non-operative treatment, which will be most of our patients, we only have left operative treatment. What are we going to do with those patients that we say we do surgery for them? We have either reconstruction techniques, the ones anybody likes most, percutaneous spinning, intramedullary nails, plate fixation, or the replacement techniques, which are hemiarthroplasty and reverse shoulder arthroplasty. So how do I choose between one or the other? The first question I ask myself is the humeral head salvageable? Is it worthwhile fixing, and can it be fixed? So if they can be fixed and they can be salvaged, I prefer reconstruction. Now, how do I know if the humeral head is salvageable? Well, we don't know for sure because all patients are variable, but we have some criteria or some predictors for ischemia, of course, and the most popular one is that published by Hertel in 2004, where if there is an anatomic neck displaced fracture or metaphyseal extension of less than 8 millimeters, medial hinge disruption over 2 millimeters, or humeral head split, if we add these factors, there is a high prediction for ischemia. Now, 4 years later, Hertel used the same population, and he said that not all his patients with ischemia necessarily went to necrosis, because there may be revascularization or creeping substitution possible if we get good fixation. So sometimes if we tweak, we can get a good fixation, we can go ahead and try for it depending on the patient. So this is a 67-year-old patient with osteopenic bone, 3-part fracture, but we see that the ischemia factors are in favor of us. We have a good metaphyseal extension, and we think we can get a good fixation, simplify this fracture and do it, then this is my preferred choice. Now this other patient, 72-year-old patient, has a similar fracture, but if we see at the 2-dimensional CT scan, we have this eggshell remaining of the humeral head. So this is what I think is not a fixable fracture. On the other hand, this is very similar fracture, 68 years old, but if we see we have some bone stock left, and it seems to be good quality bones so for these patients, if they have this varus split fracture, which is not very good tolerated, if the patient is active, I do prefer to disimpact them, reimpact them in a better position, put the plate, and then do suture augmentation for the cuff and get better alignment and better function. Now, if we do plate fixation, we always have to remember that we still have a high complication rate, approximately 30%. And the most important one, or the most common one, is the collapse into varus. How do we avoid collapse into varus? If we can, we have to give medial column stability with all these factors or tips that we can do for these patients, but this is not what we're going to talk about today. So if the humeral head is not salvageable, and I think the fracture is not fixable, and if it's an elderly patient, we go for replacement. Of course, if it is a young and active patient, we do our best for reconstruction. But if not, we go for replacement. And we have two options, hemiarthroplasty and reverse shoulder arthroplasty. Now, the current trend today is that hemiarthroplasty is being less and less used in compared to reverse shoulder arthroplasty. Reverse shoulder arthroplasty is really growing, especially during these last years. Now, why are we not using hemiarthroplasty so much? Well, because hemiarthroplasty, the technique is, it's not only just to take the head out and use the hemiarthroplasty as a spacer. If we don't get the tuberosity fixation right, then this patient will indirectly have no rotator cuff. And as the deltoid tractions, the head will just rise, it'll impact, and we will have like an orthopaedic rotator cuff deficiency. The humeral head is not stable. If we get the fixation like we want it to be, we will have a stable fulcrum of motion, And that is how the patient will do well. But hemiarthroplasty is challenging because we have to get the humeral head size right, the orientation right, the depth of the stem right, and then we also have to get a stable fixation of the tuberosities, and then we have to wait for them to heal. So it ends up being a complex surgery, and it's not very, very predictable. So unless we get them like this, we get them to heal in a very concentric manner with stable fulcrum of motion, patients will actually do very well. But approximately 50% of the patients with hemiarthroplasty can only raise their arm to 90 degrees. So reverse shoulder arthroplasty, this is our current trend. Why? Because it may get away without tuberosity healing. It has a more predictable outcome than hemiarthroplasty because it is a semi-constrained type of prosthesis. So the center, the fulcrum of rotation will be stable. We do the tuberosity fixation anyway because the patient will get better rotation probably if we do. But there are a lot of studies now that have shown better functional results and less revision rate with reverse shoulder arthroplasty than hemiarthroplasty for proximal humerus fractures in elderly patients. So this is our choice for reverse shoulder arthroplasty in these patients, elderly patients, where we see that the tuberosities are not fixable or they are comminuted. So it's exactly the same procedure as the hemiarthroplasty, but we have to address the glenoid, of course, and put our glenosphere right, have good orientation, and then the same. For the stem part, we have to get the height right adequately so we can fix the tuberosities where we want, and we can get the tensile load of the deltoid correctly. So it has its issues as well, but the functional outcome is more predictable, especially for elevation in these patients. So for final considerations, as there's increased life expectancy and this range of patients are very different one from the other, we have to individualize our treatment options. We have to analyze very well what is the chronologic age versus the physiologic age of these patients, what are their expectations, and if we choose to do surgery for them, try to reduce as many unnecessary risks as we can to make it a one-time procedure. Thank you very much for your attention, and I would like to invite you to visit our webpage, orthofleximal.com, where you have surgical techniques, step-by-step procedures. Thank you very much.
Thank you very much, Juan Pablo. I don't see so far a question for you. Any one of the group, of the Zoom group, want to make a question to Juan?
Yeah, thanks, Juan, for your talk. Which kind of sutures are you using for fix the tuberosities in hemiarthroplasty or reverse?
Hemiarthroplasty or reverse, I'm using the strong Ethibond sutures, Ethibond 5.0, the same you would use for Achilles or big tendon, a non-reabsorbable strong suture. Yes.
And in cases of reverse, are you fixing the tuberosities too, or you leave alone?
Yes, no, I do my best to fix the tuberosities. It has been shown that it gets better rotation. Some studies say that you also get better elevation, but especially rotation, internal and external rotation. And I also try not to leave them on their own because I think that if the greater tuberosity pulls out on the top, you will have some less motion because of subacromial pain. I try to fix it, not remove it.
Ashish, there is a question for you related to the type 5 glenoid fractures, including the coracoid. Also, Ram and Miguel can answer this or give their opinion. Do you prefer open or arthroscopic approach? Can you hear me?
Can you repeat that, Daniel?
Yes, of course. For type 5 glenoid fractures, including the coracoid, do you prefer an open approach or arthroscopic approach?
Well, as far as I'm concerned, I think I will use an open approach because the type 5 are unstable and there are multiple fragment bits there. But if there's a large intra-articular component, I can use a scope inside just to check the reduction. But usually these are lengthy approaches and lengthy operations, and sometimes I need a posterior and anterior approach. So we like to keep it simple. It is easy to mention arthroscopy, but you must understand that patient in the beach chair, you have got an arthroscopy screen, you have got a C-arm screen, both are positioned, and you have to monitor both of them with the scope inside. So it can get tedious. So I would keep them for much more simpler approaches, like the type 2 and the type 3 Eidberg, which is exactly what Miguel dwelled on.
Good.
Agree.
You agree, Ram? Miguel, do you agree?
I agree with that. But I don't hesitate, like the one patient I shown. Sorry, Miguel.
Oh. Who?
You want to speak?
See, no.
I agree with that. Basically, you should be prepared in a type 5. Sometime you might need to address a combined approach. If there's a combined approach planned, I just do the posterior first and then come back to anterior. But it is also possible to use, one case I have done, late presentation. I have used a Letarge plate, like 2 screws fixation, like one case Ashish also showed, just to put 1 screw on the top, 1 screw below, and then you can tighten that. So that is also a possible way to fix that fracture from the front.
Good. Miguel?
Dani, yo creo que vale recordar.
I think that we should remember, because probably not all the people who are not very familiar with this type of fracture, type 5 is a fracture that literally divides the glenoid and goes from one rim to the other. So it crosses the whole scapular body, but also there are loose fragments that can be inferior, superior, etc., or there can be comminution. So clearly, these are not fractures to be approached solely through arthroscopy, but as has been well said, to control eventually the reductions. If the fragments are inferior, the approach will be posterior, and sometimes if there is a marked impaction of the upper scapula, we can try in those cases to reduce fixating the superior angle, which can help us fixate, but the approach is basically open.
Good. Thank you very much, Miguel. So now to finish, we will go to a case that we will discuss. Federico Alfano will present it. Federico.
Okay. Thank you very much, Daniel. Okay. And thank you very much, all of you, for the invitation. I will show you a case of a 70-year-old male patient who presented with severe right shoulder pain after a direct violent trauma, no associated injuries. This was the initial radiologic evaluation, the X-ray on the left. It is a AP thorax view. It is not an IP true view of the shoulder, though I think it is a pertinent view for acromial injury and AC joint injury too. And the one on the right, it is a scapular wide view. It gives us a profile view of the scapula, and this is a pertinent view to assess suspected scapular fractures. As we can see, there's a displaced fragment of the acromial process with disruption of the AC joint and a reduction of the subacromial space. Despite the AC joint disruption, as we can see here in the AP thorax view, the CC ligaments, I mean the coracoclavicular ligaments, didn't suffer during the injury. So I believe that just fixing the fracture it's enough. Maybe this kind of lesion behaves as a type 2 of Rockwood classification for AC joint dislocation. So we can solve this problem without addressing the AC joint. This is an axial CT scan view. Here we can see that it's a kind of distal fracture of the acromion process. And following Kahn's classification, we can say it's a type 3 because we have a displaced fragment with a reduction of the subacromial space. As it is a distal fragment, some can consider the excision of the acromial fragment. This has been reported, but it can result in substantial weakness of the deltoid muscles, and this is something we have to avoid. So I would recommend to fix the fracture. Moreover, as we know, the acromion provides one side of the AC joint and serves as the point of attachment for the deltoid muscle and the coracoacromial ligament, which provides anterior superior stability to the glenohumeral joint. In addition, the acromion, by being part of the roof of the glenohumeral joint, it provides posterior superior stability too. And finally, as it is a type 3 type of fracture, the subacromial space is compromised by the inferior pull of the deltoid muscle on the acromial fragment. So open reduction and interfixation is advocated to prevent secondary impingement too. We can decide between tension bind wiring, Kitchener wire, staples, lag screws, and even plates. But as it is a distal fragment, I decided to do some tension bind wiring. I perform an open surgery with the patient in beach chair position under general anesthesia and an interscanal regional block. I perform a vertical incision following Langer lines. I believe that the success of this procedure depends on the fracture fixation itself, but on the biologic healing too. So here the dissection should be done proximal to the anterior end of the acromion process, since the vascular supply comes from the anterior part. Okay, so this is how I fix the fracture using the tension bind wiring. Some plain X-rays were performed during the first day post-operatively just to document fracture reduction. This is axillary view at the same point of time. The blue arrow is at the location of the acromion process fracture. These are some X-rays 4 weeks after the initial surgery. So the patient was placed on an arm pouch sling for 4 weeks. After that time, the sling was discontinued and active range of motion and physical therapy was initiated. At 3 months of follow-up, the patient suffered this kind of complication, maybe a skin irritation from the inside. I believe that one of the key wires was too proud, so I decided to remove all kinds of implants, and these are the final X-rays in an thorax view and axillary view. We can see the fracture healing and the subacromial space restored. This is a CT scan comparison at 6 month follow-up between that point of time and the initial CT scan, where we can see that the fracture has already healed and bone remodeling too. But this is a CT scan at the same point of time in a coronal view. Thank you very much for your attention.
Great case, Federico. Do you want to say something? Ram, Ashish, Miguel, Ashish?
Federico, excellent case. I would have done exactly the same thing. A slight change in narrative that I would have preferred was instead of the cerclage wire, I use the same 2K wires that you did, but instead of the cerclage wire, I use a Mercelin tape. I picked this up from Cape Town, Joe de Beer. And what happens is if you use a Mercelin, because the deltoid has to be removed, so we use osteoperiosteal deltoid flap, and the Mercelin tape will allow it to heal back. And after 3 months, we remove the K-wire, so there's no metal implant inside. Because it is superficial, sometimes the patients complain of feeling the wire and irritability and the skin problem. But the end result is exactly the same as you have done. So it's a minimal invasive, very nice technique, well executed.
Okay,
Thank you
very much.
Ashish. Miguel, do you want to say something?
Sí, el otro día comentábamos también acerca de este tipo de
Yes, we commented the other day about this type of fracture. It's not just because it's grade 3 of the classification of acromial fracture, but it means that it's the most proximal fracture of the acromion, and it has a high degree of mechanical instability because of the mechanical requirements of the posterior deltoid and the trapezium, and the resolution there, and I fully agree that with a good tension band is enough. If the fracture had been 1 or 2 centimeters more proximal, then we would speak of fracture of the scapular spine. And in that case, I would have preferred reduction and stabilization with a compressive plate. The notion that we should keep in our minds is that these fractures, even if they are not largely displaced, and I refer to those that are proximal of the acromion or of the spine, no matter how little displaced they are in workers or in patients with important mechanical needs, it's important to always fix, because although they are isolated and not very frequent fractures when compared to other scapular fractures, they have a high incidence of a lack of consolidation or of healing if you don't fix them, especially in that type of patient. But the resolution of the case was spectacular, I think.
Thank you very much, Miguel. Well, we are running out of time. I think it was a great session. We have a general idea of the options that we have to deal with fractures of the shoulder girdle. So, and this is historical, it's our first meeting. I'm sure that we will keep on doing other things. It was great and a very nice atmosphere. So Ram, if you want, as a president of the Indian Shoulder and Elbow Society, to say something.
Yes, thank you, Daniel. And thank you all our Argentinian colleagues. Thank you for the president, as well as Lydia, the translator, to translate this event in Spanish to reach a wider audience. It's a great privilege to be joining with Argentinian Shoulder Elbow Society. See, now we are united by Corona. So we could, for last year, we had to travel so far to Buenos Aires to see you, to have a conference. But now we are having a conference straight from our home place. So it's nice to have more continual sharing of education like this in the Shoulder Elbow Society. Thank you very much. Thank you.
Ashish?
Yes, indeed, I think this is a very good opportunity and very convenient. Perhaps we'll fine tune the time to suit the Argentinian time as well. But we really appreciated all the talks from Juan Martin and Juan Pablo, and the contribution from Miguel as well. We would like to continue this interaction and maintain these ties. And Daniel, you continue to be the glue between the two countries. Thank you very much. Gracias.
Thank you. I want also to thank Dr. Ashok Pali, that he was involved in the technical features, Lydia, and thank you all. A big hug to all, and take care.
Thank you.
Thank you very much.
Namaste.
Thank you. Thank you. Namaste. Thank you, Neeraj. Thank you, team.
Thank you,
Bye.
Neeraj.
Bye. Stay safe.
Bueno, muy bien, doctores, están fuera de la conexión, ¿eh? Ya estamos. Ha salido todo muy bien.
Buenísimo, ¿no?
Bueno, muchas gracias. Gracias, Gustavo. Hasta luego.
Listo. Chao, nos vemos. Gracias. Buen fin de. Nos vemos. Que anden bien. Hasta luego.
Un abrazo. Chao.
Se fue, Daniel. Chao. Nos vemos. Que andes bien. Chao, chao.